Hi, this is Sean Murphy of SK Murphy. Welcome to today's PATCA briefing by John Faulkner on electronic health records. PATCA is a professional and technical consultants organization. You can learn more about us at patca.org. We're fortunate today to have John Faulkner. He's an electronic health records consultant for Epic Software. John is passionate about women's health and dedicated to improving nurses and doctors' experience within hospitals. With 12 years of experience providing technical leadership for organizations with up to 40,000 employees, he dramatically improves workflow processes and has a solid commitment to increasing usability. He strives to reduce the stress and burden of technology that clinicians feel today. John, welcome.
Thank you for having me. I appreciate it. We'll go ahead and get started. So the presentation topic I have today is too many clicks, how to give doctors and nurses their life back. So let's go ahead and get started then. Just a little bit about who I am, like what do I do? So first and foremost, I always think of myself as a father. So I have four kids, they're all under four. I have 4-year-old twins. I have a 2-year-old, and then I have a 5-month-old as well. So I have a pretty busy household. You might, if you're lucky enough, you can probably hear them today in the background. I'm also a husband to a physician, an OBGYN. I've been with her since she was 19 years old. So pre-med, residency, medical school, the whole caboodle. I've been through the entire process. So I have a really good understanding of what that looks like as a physician. And I've also worked with nurses quite often too. And I have nurses in my family that are OB nurses too, as well. So primarily what I do as a consultant in my work. So I'm an electronic health record consultant. I work specifically with Epic software. And my specialty is women's health is what I'm primarily working on. So over half the hospital beds across the US use Epic, which is a pretty staggering number if you think about it. So if you go to a hospital, most likely there's a 1 in 2 chance that they're using Epic. 325 million patients have an EHR in Epic, which is huge. And then they have the largest EHR market share in the entire world. And that's, across Europe, that's everywhere. They even have it in Africa as well. The largest vendors that are really well known out there, you may have heard of before, is Epic, Cerner, Meditech. And then there's over 600 companies that offer their version of EHRs, which is kind of another mind-boggling statistic. People are constantly trying to create their own EHRs, trying to find a better software to help doctors and nurses and all the hospital staff, not dread their EHR system. So some terminology I wanted to get through first is that, what are electronic health records? I hear the term used a lot, like EHRs versus EMRs. It's important to know that EMRs are linear. They only go one way. So for example, maybe you were at an outside clinic away from a hospital. Your results may, go to the hospital, but they may not go from the hospital back to the clinic. So there's not two-way communication with interfaces. So that can be an issue. And also the patient care, if you think about it, the doctor gets frustrated because they can't find results. That's one issue. EHRs, they do communicate with hospitals, labs, they communicate with payers as well, so insurance companies, and they can usually query data from those insurance companies in real time. So if you're at check-in, they'll query it through what's called real-time eligibility, and they can see what is your insurance, what is actually, your primary, secondary, or tertiary insurance. It's also known as like the elite of the software in the medical industry is how you can think about EHRs. EMRs are kind of older. First came out in the 70s. That's when it all first started. So this is just a little bit more about Epic. You can go to epic.com later if you're trying to look for more information. Kind of an interesting story. So the CEO, her name is Judy Faulkner. I'm not actually related to her at all, but it always makes a good conversation piece when I'm talking to potential clients or people that are using Epic. Everyone always asks me, is she your aunt? That's like the first question I always get. And no, I'm not related to her at all. But it's also interesting too, because it was developed like in a basement, but the language for Epic actually started from Mass General in the early 70s. It's from a programming language called MUMPS is the name of it. It's a cache language. It's good for storage for healthcare data specifically. And that's what they use to program their systems today. MUMPS and then also like XML. I see that used a lot. They get involved with basically any kind of aspect of medical care you can think of. They work with clinics, they work with medical centers, large hospitals, small hospitals. They do have requirements about the amount of encounters you see per year. It's usually like 1 million encounters per year is like their client threshold. So those are all things to think about. And then the name itself, it's it's from like the Iliad and the Odyssey, which I think was kind of cool. And I just learned that a couple of years ago. And it's really a chronicle of the story of a patient's healthcare over time. And that really, in a nutshell, explains Epic very well. You can see it from the very beginning, from the first time a patient entered Epic to the very end, when maybe they passed away in the hospital. You can see all that information as well. So it carries that entire story of events. This is more specifics about how I help them. So when a hospital purchases Epic, you may have seen it like in the news. Maybe they've switched from Cerner to Epic. That happens a lot. That's a legacy system. That happens all the time. Epic sells their software out of the box um, without any customization. It'd be like just getting like your Word document software or Excel or another document just out of the box, which is what everyone gets. So I can come in and customize it for them and program it at a certain level, but I don't actually get into the source code, like the nitty gritty. I don't own any of that. I can't see that. I build it for them, kind of like this pyramid model here. I can customize it. There's different modules within Epic. Stork is the module that's my specialty. So that's women's health. So that I just wanted to kind of give you that brief overview of how that works and see how it's structured. Okay, so let's think more about OBGYNs and OB nurses and how this affects them. So a lot of times when consultants come into hospitals, they might be assigned to like the help desk, like resolving tickets that nurses may have called into the help desk that now it's on the Stork team, that women's health team, and they have to resolve it. But these are other factors that, like an analyst just starting out or like a new analyst don't think about is like, so an OBGYN, they can have kind of a mix of clinic and labor delivery, or they can just be a laborist, which is basically they're in the hospital just delivering babies all day long for up to 12 to 24 hours or even longer. OB nurses, kind of similar, a little lighter, shift assignment, usually 2 to 3 patients on a shift, 8 to 12 hour shifts. And then they usually can work outpatient too, like the physician, but it varies by the clinic. If you're doing like a high risk clinic, moms might have some medical complications or something else going on. So that's just something to think about with the work schedule. And then as far as working in Epic, what does an OBGYN do most of the time? Usually it's writing notes, placing orders, working at the patient portal, which I'm sure you guys have heard about before. My chart is the common word, and in basket. So those are all those messages that you're sending to your doctor, they're writing back. It's one of the things they often complain about too in their work. Nurses are typically living in the flow sheets, documentation, orders, notes, and then communicating like handoff between shifts. That's what doctors are doing as well. The personal factors that are driving a lot of like the frustration that I end up getting because maybe everyone gets frustrated with technology when it's not working. These are things that are not always thought about, like what's going on in their family life, like how is their health? Do they come from medical leave? Did they just have a baby? There's all these things that people don't think about. They're losing time, or maybe, hey, they're spending 2 to 3 hours every night in the patient portal to catch up that they're not getting paid for. So those are all things that are kind of roped into their life. Some other work factors that need to be accounted for too is hospital leadership. There's regulating bodies that are constantly breathing down their neck because they need to do something a certain way and it's not their decision. It's what the government told them. It could have been CMS. It could have been a payer that told them they need this in their notes. So there's constantly micromanagement going on within the healthcare system today that's causing a lot of the frustration. And then the last part of that is revenue. They're always looking at where's the revenue loss. They call it revenue cycle is the terminology that they often use. And they're always concerned about, well, if we're losing revenue, are they going to have to close the department or are we going to have to restructure or change things around? So another big part of that is looking at reporting and analytics. So then they can make decisions on how to, build physical buildings and then maybe implement Epic in another center, maybe like a women's specific health center. Those are things that they look at too. And then the result of all these things that just compound over time is stress. You know, you're putting the needs when you're in a nurse and a physician above everyone else except yourself. So what that leads to is physician burnout. People are frustrated. They're dealing with what I anecdotally hear a lot of times is, people that don't get their life. So empathy goes a long ways when you're working with these folks, just acknowledging what is, what they're frustrated with, not justifying your role in your job. And then looking at the expectations, OBGYNs have higher than most. They're in a very litigious specialty, which means out of all the physician specialties, they probably get sued the most out of all the specialties that are out there. They're constantly having to look at fetal monitoring. There's, that causes a lot of stress. And then the same with the nursing staff, because like your name could be named in a court case, and then now you have to go to court to talk about that. So these are all just things I want you to kind of keep in mind as we're going through here. I did put Maslow's on the side if you took any psychology classes. These are all things that are usually driving people that I've seen as well. So this just reemphasizes that concept. So what this ends up leading to is something called decision fatigue. This is actually a real thing. I talked to my wife about it too, and she gets the same problem. And like another story just personally. So like, for example, if we are buying Christmas gifts for the kids or doing anything like personal tasks, our to-do list usually keeps growing because we can't make a decision because I want her to help me make it. She can't make it because she's burned out because she's been making decisions all day long. So I'll look at my Amazon cart and I'll have like 40 things in there, but nothing's been purchased. So that's something that affects the staff. That's just very detrimental because it's just mental overload, like it's talking about here. It's just, you just don't want to think about it, but you can't get it off your plate. And it just keeps building over the course of a day. So by the time you get home, you can imagine you may have seen 40 patients during the day as an OBGYN. You're completely burnt out at the end of the day. You don't want to make a decision about what to eat for dinner. You may not even want to eat dinner because that's just one more thing you got to do in the day. You may have heard people talk about brain fog, doing nothing, impulsivity, like not really thinking things through, avoidance. Maybe they just want to completely isolate so they're not being asked questions. These are some solutions that this article on the bottom provides, and I actually agree with too. So delegation is huge. So for example, if you are a physician, think about who can do your yard for you, like who can mow your grass, just little things like that to delegate so you don't have to think about it, make a decision, streamline your choices on things that you actually have to make a decision on. Save the big decisions in the morning, which I think this is a really interesting point, because if you think about it, your cup is partially full in the morning. At the end of the day, you probably don't want to make a big decision on should we buy a house or not, right? So those are things to think about. Stop second guessing yourself. Develop some daily routines if you can. And then as always, if symptoms get worse, seek help. And I just thought this was really interesting. This is an article I found, but I've been talking about this for a long time. And again, specific to EHRs, get into that. This is what we can do to help these very critical staff supporting women going through pregnancy, going through delivery. We need to create less decisions to make within Epic, not more. So that's my goal when I work with newer analysts and people building in the system. People are always, well, Dr. Smith wants this. And I'm like, well, Dr. Smith might not be thinking about the 200 OBGYNs that are in the medical group. So we need to think about how is this going to affect everyone else. It might feel like a great idea, but it may not be. So how is this going to affect everyone else? Going to that point too is evaluating patient alerts in the system, the number of alerts, frequencies, accuracy of those alerts. So you might have an alert, for an example, on a patient that's like a postpartum hemorrhage risk, which means that they could bleed out shortly after delivery. That's a high risk thing that's tracked everywhere. Is it evaluating the patient correctly? Do you have the checks in place? Is it not alerting when it should be alerting, like giving you a heads up? Reviewing your orders. And then whenever I look at orders, I want to ask a question like, how can we improve these with less decisions? how can we make this, I call it in a way dummy proof, so you don't have to think as much. It's just right there. Even items are already populated, and then you just hit sign to make it easy. Speed up the workflow, and then it standardizes it for everyone else. Another thing to look at too is a common complaint is the notes. Not just OBGYNs, but all physicians complain about notes. No physicians are writing their notes exactly the same. The issue with this is that it always goes back to billing, or you can't find out what's going on with the patient. So these are all delays in care that could add hours or days in patient's care overall. Some other things to look at it for as well. Think about where staff have been complaining about for months or years. Like oftentimes I come in an organization, they're like, well, this issue's been broken. This has been going on for years. I'm like, okay, what's the next step? That's what I always ask, those tough questions. And no one can give me an answer. So I just do what I do. I keep asking questions until I get an answer. And try to make some progress on those barriers if I can. We've already talked about delegating task, and then questioning everything in your Epic. Like, why do we do this? What is the purpose? And think about the progression too. Like maybe you implemented Epic 10 years ago, 5 years ago. Things change over time, and people like myself, a consultant might only be there for 6 months. Then they leave, but no one knew why those things were programmed in the system or built that way. So we need to understand the story of why are those things there? Why is it not working? Do we even need it anymore? So making sure to question those things. And then the last thing is just your reporting and analytics. Like, do you have everything that you need? Can you quickly report to government agencies that ask for specific information? For example, maybe you have to report on that postpartum hemorrhage risk data, but you don't know how to get it out of Epic. You think it'd be easy, but if those reports are not in place, you can't easily query that data to those regulating bodies. So a lot of good questions and things to think about. One of the topics that's like a hot topic now, I couldn't make this presentation without talking about it because everyone, again, is trying to find like the solution to making physicians' lives and nurses' lives easier. These are the milestones that have been occurring in the past, I'd say like year or so. So in October 2023, President Biden, he signed an executive order. There's the very long name there, as you can read. And then in May, there was a roadmap for artificial intelligence policy in the U.S. Senate, was developed by an AI work group because there was concerns of ethics being involved. Like, where is that data being queried from? Where is it? How is it gathering this information and then provide this output to me so I can see it? And then more recently, within this year as well, Governor Jared Polis signed a state law regulating use of AI in the private sector. And this is including healthcare, which is huge because it sets a precedent for other states to now get involved and ride on that bandwagon, if you will, with artificial intelligence. Specific to Epic, so these two bodies met. So UW Health was one of the original Epic customers because Epic is based in Verona, Wisconsin. So they teamed up. They went to Washington, D.C. on June 5th of this year, and they focused on AI through the perspective of healthcare delivery and the patient provider experience. So like, what does that really mean? It's like a big topic, right? So the themes they focused on were AI's potential, like what can it actually do in healthcare to make our life easier? How can we actually utilize it? Workforce shortage was one of them. A critical need for transparency as I reaches the point of care too. So what that is really getting to is how is AI going to interact with the patient? That's how I read that sentence. So how I see it today is it's used in the in-baskets, it's used in patient portals. It's being piloted in organizations right now. And that's how they're trying to make it better for staff. And obviously messages can be edited, but it gathers a really good, synopsis of what's going on with the patient in their chart in that recent message and generates some data. And then the real important piece too is what this is like AI is such a broad topic, but you need to take in like the local atmosphere to ensure like the efficacy across a diverse patient group. Because like if you look, for example, like like I'm in Detroit, it's a very diverse population, right? But if you go to like California or Florida, then you're reaching different types of people, different backgrounds. So you have to think about, how efficient is this for our patients that we see today? Is it going to work for us? And then if not, how can we make it work for us? Epic is using these following things with their customers. And this is all widely available. This is on the web. This is not like secret information. So they're generating in-basket messages to my chart messages today. They're writing visit notes based on the conversation during the office visit with something called ambient voice technology. So this is kind of cool. So they might be logged into Epic, but then the AI is collecting all the information and writes a note for them at the end of the conversation and puts it in a note. So the doctor doesn't have to write the note and spend 30 to 45 minutes or longer writing one note. It's already pre-populated. It's up there on their screen for them, and they just have to validate and edit and then sign it. Another one is looking at like dashboards for key takeaways. So it searches the patient's chart. So this is kind of neat too. So Epic does have like a search functionality within the patient's chart today, but this is actually making it like a smarter search, is my interpretation. Kind of like a Google search, if you will. It's a good way to think about it. And then we can also look at the next piece here, summarizing recent notes before a visit, which I think is critically important, especially if you're a provider who've not seen that patient before. Maybe it's a new patient. It's good to know what's the story, what's going on with them. Were they hospitalized? Maybe this is a mom who hasn't had any prenatal care and it's month 6 and they show up to the clinic, right?
So John, we have two questions came in. This slide
Yeah.
triggered a lot of thought. First question is, are you going to be able to make the slides available to the attendees?
Yeah. Just let me know, Teresa, do you want me to send it to you?
Yeah, if you make it
Yeah.
Teresa. Second question is, do the notes that are collected via ambient technology also create a workflow? For example, can they prep a test order?
I think that's their plan. I haven't seen them do that yet. Right now, they're trying to work on the note specifically, but I don't know if it's smart enough yet to listen to the conversation and be like, okay, order a CMP, BMP, and all these different things. I don't know if it's smart enough to do that yet.
Okay.
Were there any other questions before I move
Just
on?
those two. Sorry, those great
Yeah,
answers. Thank you.
yeah, no problem. And then this is an interesting one too. And some of these features, I think this bottom one might be a work in progress still. So they're extracting the follow-ups for imaging reports. And I think part of that too is actually probably reading the imaging study and saying like, is this an abnormal result? Trying to go through that information and what is the follow-up. And I don't think they're going as far as that as like interpreting the image. That's why we have radiologists. But I think if I was to be like a futurist, if you will, that's probably where they're going to go down the road, is the interpretation of those things. So just some things to think about as we're going through this. This is purely my perspective of consulting in like my 12 years within Epic since 2012. These are things I hear again and again and again. It doesn't matter if someone's using Epic in California or if they're using it in New York, it doesn't matter. These are the frustrations I constantly hear. So number one is slow implementation of critical features. This could be something like maybe, hey, we need an alert for the flu shot because it's flu season. And we need to give this to patients. Or, hey, Doctor so-and-so hasn't done his training yet, so you have to take away his access because he didn't do the training. So there's like things like that that are just very slow on the IT end if there's not a good change control process in place. There's a lot of what I see as like reactionary things happening in IT. So like we will typically wait until something bad happens and then fix it instead of being proactive and be like, okay, here we go. Like we obviously have failover systems and all these things, but I feel personally we can be more proactive about preventing issues in the EHR. Slow change control, some things might take something for me to program might take 5 minutes, but then it takes 2 months to get through change control to then be used by some staff member. which I find to be completely not, acceptable. I just think that's too long. So there's ways we need to look at this from a lean perspective. How can we make this better? A lot of the things I find too is that there's a huge disconnect between IT staff and the hospital staff because they don't necessarily understand the workflows. And I'm not saying for everybody, this is again just a trend. The hospitals that get it, they send their staff out to the units or the clinic and actually shadow those staff members to understand what do they do on a daily basis. If that's not happening, it's very hard for staff to support traditionally. A lot of times, depending on like upgrades and things, there's too many changes too quickly. People complain about that. You may have the same issue like on your iPhone or your smart device. There's too many updates. It's kind of the same complaint that I hear a lot. And probably the most difficult thing that I've seen that affects all of healthcare is the next one. So finding out what needs to happen with patients from notes and chart documentation. Especially if you have patients that are very high risk or have had a lot of hospitalizations or on like a lot of medications, it's really difficult to try and figure out, what's going on with this patient now and what do I need to do? Like, what did the other physician say or other, practitioner, what did they say about what to do next? Another kind of like technical issue is that they may not be able to see outside results easily, or they may not be updated right away in real time, which can be immensely frustrating as well. There is a slow response time to take it submitted to the help desk. So when you call the help desk, how it's set up for basically every hospital or medical center is you have a tier 1 help desk and they're taking the ticket. They're just translating what you're saying and then sending it off to me, basically. And when I say me, I just mean like an Epic analyst. Then from there, it's being triaged to another team, which is then those Epic modules. Does this go to the Stork team? Does this go to the inpatient team, the outpatient team? And not a times the ticket gets lost. I've seen that happen a lot. And then the last one is issues that are ongoing for months or years, never resolved. The criticality of them is not communicated well at either end. And they just never get fixed, which is a shame. So this is like my recipe. I didn't have like
before you move
Yeah.
on, I think Kate had a question.
Yeah, go ahead, Kate.
So in chat, it says, what do you think of patients' frustration with the Epic MyChart? Any data on this?
I don't have data in front of me or that I've seen, but specific to frustrations that they have that I've seen, because there's also an Epic team that works with them that I work with it frequently. I hear anecdotally again, they want to like easily maybe set up a proxy, just thinking from the women's health side for like a newborn baby, trying to figure out how to attach, like maybe just make attachments for results is something that I've seen too, and just navigating, they're constantly updating the features to try to make it better. But the other problem with that too, like at least the data I have seen recently is showing that it's really focusing on usage of MyChart in the patient portal. And that does vary based on population, because maybe one population doesn't have the ability to purchase a smart device or even has internet access, so they can't get to a patient portal. They might be homeless or something. So that's something that I see happen quite frequently. And how do you reach out to those people, right? And how do you remind them, hey, you have an appointment, you have type 1, you're a type 1 diabetic and you need to get into the clinic. How do we get out to that person? A lot of times what they do is have like a mobile unit they end up creating and deploying. So that happens too.
Thanks, John. That's great.
Yeah, you're welcome. This is my recipe that I wanted to show you guys. It's not a really good image, but this is the best I could come up with. This is like the better future for Epic, just to keep these in mind, that I try to get across to people that I work with is rapport. I didn't put a number on it, but that number one, I would say, is rapport, building a relationship with the people that are actually using Epic to empathize what their life is like. You know, when you log into their device and they're clicking, you're counting the clicks. You know, they maybe click 10 times to just place an order. Like that's crazy to me. Like it should be easy, right? Why can't we make it easy? Those are all questions I always have. Um, Agility, that's like the speed of kind of starting at point A and getting to point Z. Working on the speed of like what are the barriers, what are the delays and getting resolution. And then circling around to trust, which is really huge, is that the hospital staff has to trust the IT staff that when the IT staff says, hey, we're going to resolve this by X date, we need to actually follow through on that promise and get it done for them. Because if we're missing dates and not following through, it just creates, again, lack of rapport, lack of agility, and it causes people to be frustrated. And then goes to the last one, which is efficiency. It just leads to all sorts of problems across the board. So these are like conceptually the things I like to think about of what makes an ideal Epic. And this is really what it is like the best organizations that are using Epic today, they complete all of these at 100%. And that's why I put 1 cup at each one is if you're doing these things, your Epic is in a really good state. Any questions about this one? Okay, click through. This slide is just for like any questions you have or comments or, and also just how to get in contact with me if you have other questions after the presentation. I'm always happy to connect with people. Any questions? Just want to open the
So
floor.
I have a question. I notice a consistent theme that you're always trying to lower the click count. And I'm curious if there's some audit that you can perform for a hospital or a department that looks at current implementations and sees where there are opportunities to streamline or to cut them. Is that a service that you offer, or how do they may not even realize that they're taking the long way around the barn, right?
Correct. Yeah. The Epic has reports that they can run audit reports of those things, like usage reports is what they call them. So you can actually see, you can track how long it takes that person to go from point A to point B to place an order. And it actually will tell you in the system the exact location where they're clicking, which is really cool to see. So those are like data and reports that you can like pull out of the system. Like my thing is less clicks, but like I showed you today, it's a lot more to that. Obviously, the concept is like what's going to make you happier, right? Because nothing bothers me more when I come in and I see staff just completely miserable. They hate Epic. They're stressed beyond belief, and that's how I like to work as a consultant.
We have a question from Anat,
Yeah.
which is how you solve documenting the business logic for current and future users. In particular, why are we using this feature? Why did we change the settings? How do you take people through a change process?
Yeah. So when I get let's just start with a new feature, right? So there's release notes that are released by Epic on specific intervals that are reviewed by us, like consultants or Epic analysts, let's say every 3 months, right? So the process for that is we read the note, we say, okay, this is a change that's going to affect maybe a postpartum hemorrhage report, and maybe it's like criteria in the report. So I have to build that in our development system, test it, validate it, move it on to the next test environment. And then right before upgrade and right at upgrade, we move it into what we call the live or production environment. Throughout that process, though, there's unit testing within the module, so that women's health module. And then we have integrated testing at the end, which is like with all the devices and the interfaces, all the fun jazz, just to make sure things are working properly. So postpartum hemorrhage risk, we don't have devices, but let's for like glucose testing, usually there's devices working with the system or vitals machines in the Epic. That's part of the testing. And then getting things into the environment once everything's been validated. So that's like a high level explanation. Hopefully that helps.
No, thank you.
Yeah.
We uh we had several questions on AI, and I just wanted to know if Kate, we addressed your questions about AI. He had quite a bit up there, but there's quite a bit to it.
You know what? I think we could talk about it for weeks. But I think John did a great job, I think, of providing that context and insight to where the industry is right now. So I really appreciate John's talk today. Thank you.
Yeah, this would make a great article on the PACA website, John. Teresa, you have a question?
Well, so in a recent engagement, what were some of the biggest challenges you helped overcome?
So I would say reporting is probably the biggest, the most recent thing that I've had to help organizations with, is that they may not know that they're losing 15 to $20 million on an engagement until you run a report. And then you're like, oh, where are all these moms going? They had their prenatal care at our clinics for 8 months, but now they're delivering somewhere else. The result of that is, like, financially, is that a C-section is usually $12,000 to $16,000. A vaginal delivery might be $6,000 to $8,000. So if you think about, you did all that work to get the mom to just about deliver, now they chose a different hospital. So if you can track that data in Epic over, say, like 2 or 3 years, you may have lost millions of dollars. And that's an opportunity that might be leading to, like, closing of a facility. That's a lot of money, right? Or a department or something. So those are the things that I love getting insight on, and like what the bigger story of where are these patients going? Why is there mismatches? That sort of thing.
Very interesting.
Yeah.
Have you done anything with process data mining out of the transaction records?
So I've worked with, it would be like our revenue cycle team. So I've looked at specific data models for that. Looking at transactions within the system. They work out of work queues, and it's really like patient list of outstanding balances. Those transactions that may have been open for 6 months or 12 months. And maybe the payer just keeps denying the claim because the doctor didn't say these 3 words in his note or something. It's really weird stuff like that can lead to a denial. So those are things that I'm looking at from, like, the transaction perspective when I do that.
Do you do any visualization of the transaction records into, like, workflows or flow charts or other kinds of process diagrams?
So when I work with transactions, like in the nitty-gritty, I'll work with a certified revenue cycle person to get that information. Like, I can start with, like, this high level of what I want, but then they'll start asking specific questions of, like, like, what are you trying to get out of it? And they'll know exactly where that is in Epic to then query the data for me. It's usually what I'm doing.
Okay. Yeah, you might look at the Celonis stuff or the Fluxicon stuff in terms of another way to visualize a transaction stream.
Yeah, we have, like, there's dashboards, there's data models that there's, like, multiple different ways and diagrams and graphs to look at it.
Have you ever worked with Celonis or Fluxicon or guys like this?
I haven't, no.
Okay.
Have not.
So, okay. Alan, any questions for John before we break? Well, this was very thought provoking. I thought the couple of the slides were quite well done and quite insightful. And I'm glad we were able to have you come to PACA today and kind of give us an overview of what you offer and how you approach it. I'm going to give people a chance. If any last questions for John, I'll take them now. Otherwise, we will give you 10 minutes back in your day. And John, thanks for a fantastic job today.
Yeah, thank you. I appreciate it. It was a great opportunity. So
Thank you, John.
thank you.
All right.
Bye, guys.
Break here.